Good morning, everyone, and thank you for joining us in the Toronto International Rounds. It's my great pleasure to introduce Dr. Mackie. Dr. Mackie is a pediatric cardiologist at Stollery Children's Hospital and a professor of pediatrics at the University of Alberta. Andrew did his cardiology fellowship at Boston Children and completed a Master of Science in Epidemiology at Harvard. And one of his passions and the main topic of his research is a transition from pediatric and adult care, but not just only for the adolescent, but also focusing on the parents. And Andrew's going to talk today about transition in ACHD and is a mission complete or a failure to launch. So, Andrew, thank you very much for joining us today. It's one of my passions as well, transition. So I'm really, really looking forward to your talk. So the floor is yours.
Thank you, Rafa. It's a real honor to be invited to the Toronto International Round, so thank you for having me. I don't have any conflicts of interest. I have three objectives. By the end of this presentation, I hope you'll be able to describe the challenges encountered by transition-age youth, summarize key concepts of transition preparation and some of the existing knowledge gaps, of which we still have many, and finally identify one way of improving transition-related care within your own clinical practice. And I've structured the talk into four sections. First of all, describing where are the gaps. Second, describing some of the evidence. Third, going over where there's evidence gaps. And finally, leaving you, I hope, with some practical tips. So just to begin, so that we're all on the same page, what is transition and how does that differ from transfer? Because the two terms are often used interchangeably when they're not really quite the same thing. So transition is a process. It's the purposeful, planned preparation of adolescents and young adults in order to help them succeed in the adult healthcare system. It is meant to foster developmentally appropriate self-management skills over time. And it's not a single point in time, but rather it takes years for most young people. And it spans, importantly, both the pediatric and the adult healthcare systems. In other words, transition is not done the day the patient leaves the pediatric clinic or the day they arrive in the adult clinic for the first time. Transfer, on the other hand, is an event, and that's when responsibility for care moves to the adult clinic. Transfer is part of transition, but it's only a small part. And to make a picture of this, I view transition as a process that spans adolescence and to early adulthood. And like most things in life, it has periods of upswings and then plateaus and more plateaus. And it's not a single linear process. Whereas transfer occurs at a single point in time. And in Canada, that's typically just before the 18th birthday. Although in some jurisdictions, that can be a bit earlier, 16 or 17 years. And in some other jurisdictions, it might be later. In the US, for example, it's often 21 or 22 years of age when transfer happens. So I'd like to just provide a real case, which is one of several cases that really got me interested in this topic about 10, 15 years ago. So consider JR. He's a 23-year-old male with tetralogy, repaired in infancy. He comes to a walk-in clinic with declining exertional ability. He doesn't know the name of his congenital heart disease. He thought he was cured. He was last seen at age 17 in pediatric cardiology with free pulmonary regurgitation and a borderline RVEF, and was advised to attend the adult clinic in a year, but hey, life got in the way. He moved to another city after high school. He didn't know how to find an adult clinic and he felt okay, so he didn't bother. Now he's in a walk-in clinic and hopefully he'll get to the adult congenital heart disease clinic, although there's no guarantee that will actually happen. And so, of course, this situation is unfortunate, but entirely preventable. Why do things like this happen? Well, young adult survivors, as we know, have multiple other life transitions going on at the same time as they leave pediatric care. These include getting some post-secondary education in some cases, getting new jobs, new partners, and other life distractions. And of course, going to the ACHD clinic isn't exactly priority number one. And as you know, this is a period of changing influences for youth. Healthcare providers like you and me become, well, relatively less important in their lives, as do their parents and family members, whereas peers become a hugely greater source of influence in social media. And so these are also challenges that we and they need to deal with. Psychologists have coined the term emerging adulthood, and it's really a unique developmental period between approximately 18 and 25 years of age, when there are still anatomic and cognitive changes occurring. And anyone who has any adolescents living with them, like me, or anyone who's ever been an adolescent, can probably relate to the cartoon here. But keep in mind that a chronic health condition like moderate or complex congenital heart disease may result in additional challenges. Frequent hospitalizations and medical appointments throughout school years and adolescence can result in school absences, disconnection from peers, a higher incidence of anxiety and depression, and difficulty developing an identity outside of their illness. And all of this, of course, complicates their ability to manage their chronic illness. And so this really can be a period of high risk from a medical perspective. And there are numerous consequences of transition. Back in 2007, Michelle Gervitz published a really interesting paper where she highlighted that there's not only increasing hospitalizations in early adulthood among those with congenital heart disease, but many of them come through the emergency room because they have nowhere else to go. And we know that healthcare dropout, difficulty attaching to adult providers, poor treatment adherence, and again, increasing emergency room visits and increased hospitalizations in congenital heart disease, but also in other pediatric onset chronic health conditions. Here's a very important paper published by our colleagues in Toronto back in 2004. And this was really the first paper to describe loss to follow-up in congenital heart disease, to my knowledge. But this paper is also unique because it was the first among any pediatric onset chronic health condition to describe loss to follow-up between pediatric and adult care. And what Graham Reed and colleagues at SickKids and the Toronto General reported on was the proportion of graduates from SickKids with moderate or complex congenital heart disease who arrived in any CatchNet, any congenital clinic in Canada by 22 years of age. And 47% had not been seen by age 22. And so this is a real eye-opener for her, for us as a community. And we now know that SickKids and TGH have a terrific transition program, and I'm certain that this loss to follow-up is much, much lower, but this is really an important paper to bring attention to the problem. An earlier paper from the UK was pretty similar. This problem is not unique to Canada, of course. So here's a paper by Joe Ray where they looked at patients with tetralogy of Fallot, and 24% had not been seen within 3 years of transfer from pediatric to adult care. And in the box below are some of the reasons that patients who were brought back into care provided when they were asked why they'd had a lapse in care. And I'm not going to read these out loud. You can read them yourselves. But many of them were unaware of the need for lifelong follow-up. A more recent paper from the UK, just published 2 years ago, reports that the transfer of congenital heart patients from peds to adult services in England is much improved. But one aspect of this care that really, of this study, that really stood out for me was that the model of care really had a significant impact on the probability of arrival by 20 years of age in an adult clinic. And by model of care, they refer to a vertical or horizontal model of care. Vertical meaning the pediatric and adult congenital heart disease clinics are at the same site, same hospital complex, or the same building. Whereas a horizontal model of care was one in which they defined as the pediatric and adult sites or clinics at different physical locations. And the odds of patients with moderate or complex congenital heart disease arriving in by age 20 was about 0.44. In other words, those at a horizontal site were about half as likely to arrive by age 20, which raises all kinds of questions about why this may be, and I think we need more data, but it's certainly fascinating. The same study looked at other risk factors for not arriving by age 20. One of them was being female, which is a little bit different from other publications. Typically, males come out as being less likely to arrive in the adult clinic, but also importantly, not being white was a significant risk factor, as well as living in a deprived area, pointing out some of the social determinants of health and how they can have an impact on the success of transition and transfer. And also complexity of congenital heart disease. So patients with moderate congenital heart disease were significantly less likely to arrive than those with severe congenital heart disease. And those with simple congenital heart disease were the least likely to arrive in the adult clinic. So Philip Moons and colleagues published a systematic review about 3 years ago on discontinuity of cardiac follow-up or lapses in care. And suffice it to say that we're still not really doing quite well enough in Canada. About a quarter of our patients have lapses in care, most commonly between pediatric and adults, but not always. And sometimes lapses in care occur within the pediatric age range, I'm afraid. Our colleagues in the US have an even higher incidence of loss to follow-up, whereas in the European Union, overall, they're doing a whole lot better at 6.5% discontinuity of care. Among those with simple congenital heart disease, about a third have lapses in care. And I would say even more concerning, those with moderate and complex congenital heart disease, a very high proportion have lapses in care. And there were a very small number of studies within this systematic review that evaluated the impact of a structured formal transition program on loss to follow-up. So I would say that this is why the confidence intervals are quite wide and more data is needed, but having a transition program certainly seemed to have a positive impact. So it occurred to me a few years ago that whether or not a patient arrives in the adult clinic is a bit of a crude outcome, because if they are arriving in the clinic 5 years after they're meant to, or 10 years after they're meant to, then that's hardly a successful transfer. So I thought that we should consider this variable excess time, which is the additional time between the recommended interval between the final pediatric appointment and the first adult appointment, based on the pediatric cardiologist recommendation, and when they actually arrived in the adult appointment for the first time. And so this time difference being excess time. So if a patient is recommended to show up 12 months later, but they actually show up 3 years later, then the excess time is 2 years. And Jessica Patzer, who's an ACHD cardiologist in Calgary, and I and colleagues looked at patients across the province of Alberta. We found that the mean excess time was 8 months, which may not seem that terrible, but keep in mind that 10% of the cohort had an excess time of greater than 24 months. And we found that protective factors from having excess time are patients who had a pacemaker or ICD. And that may be because they're getting contacted for device checks and device interrogations. And that's a regular reminder about their congenital heart disease. Also, those who are on cardiac medications at the time of leaving pediatric care, probably because they have a daily reminder of their congenital heart disease. And then looking at some US data, so Kayla Lopez and her group at Texas Children's recently published a paper where a third of their cohort of about 1,000 patients, a third had an excess time of greater than 12 months. And they were able to get some of these patients back into care, and they interviewed them and found out why they'd had a lapse in care. And the most common reasons provided are on the left-hand side here: a lack or change of insurance, or inability to afford payments. Of course, there are a number of other reasons provided as well, but these two on the left here really highlight the importance of social determinants of health on being able to access congenital heart disease care, particularly in the United States, but that is not unique to the United States and is a major challenge in Canada as well. So what are the clinical impact of lapses in care? Well, there are a number of publications on this. Delayed recognition of hypertension among those with repaired coarctation. Young and colleagues published the need for urgent cardiac reinterventions in the cath lab or OR within 6-month period of arriving back in the adult clinic after a lapse in care of 3 or more years. We know that those with lapses in care and tetralogy have delayed pulmonary valve replacement for obvious reasons. If you're not in care, you're not going to have a pulmonary valve replacement. And of course, young adults and their parents have perspectives on the transition process. So let me just share a few of those. Many youth, not all, but many feel unprepared to manage their health, particularly in the absence of any education about their health. Many lack basic self-management and self-advocacy skills. They don't know where to turn for help, and so typically end up in the emergency room. Some of them feel relatively attached to their pediatric providers and have difficulty leaving. And some, of course, have cognitive delay and challenges with executive function, which, of course, make all of this more difficult. Parents, more so than youth, really struggle. They have particularly strong attachment to pediatric providers. They have difficulty letting go of the day-to-day responsibilities of managing the health condition. Making sure that their 19 or 20-year-old takes their warfarin every day, for example. Parents, more so than youth, are often wary of the adult system providers and remain extremely invested in the health of their young adult child. I was on a call with parents and others as part of the Fontan Outcomes Network recently, and the mother of one 19-year-old with a Fontan described herself as literally being terrified of the adult healthcare system. And those were her words. So that really resonated with me. And of course, providers, we have our own perspectives about this whole transition process. So as pediatric providers, we have had a 17 or 18-year relationship with the patient and family, and that can be a barrier for some pediatric providers in terms of letting go. Many feel that they lack the skills, time, and resources for transition preparation, and I totally get that because it is time consuming, and as cardiologists, we can't do it all on our own. And some pediatric cardiologists may feel that their patient isn't ready for adult health care. On the adult side, the interesting publication by Peter and colleagues in pediatrics, where they surveyed adult internists, and their major concerns were dealing with patient maturity that was not what they were used to, dealing with the heavy psychosocial needs of young adult patients, concerns about facing disability or end-of-life issues early in the relationship, the lengthy visits that these young adults require, and the family's high expectations. So everyone has a perspective on the transition process. And of course, the models of care are very different between pediatrics and adults. So in the pediatric system, we're relatively nurturing, we're family-centered, we have fewer patients to see than our ACHD colleagues. And we're generally kind of warm and fuzzy. And I'm not saying that you're not in the ACHD clinic, but certainly the adult system is much more autonomy focused, whether or not the patient's ready for it. And patients are expected to advocate for themselves, manage their own health, make treatment decisions. And youth tell us that their providers in the adult clinic seem relatively time-strapped and unavailable compared to what they're used to. So it's like jumping a big chasm. This is what many young adults describe the move as being like. So as providers, what are we actually doing to address the transition problem? Well, here's a recent publication 3 years ago, a survey of 96 European adult congenital heart disease centers, and in combination with their pediatric counterparts, they were asked to self-rate themselves on 6 different transfer criteria. I'm not going to read them out loud, but you can read them there. And they're also asked to rate themselves on 6 transition criteria. So how many of these transfer criteria were they practicing in their program, and how many of the transition criteria were they practicing? And when you map out on the y-axis transition criteria from 0 to 6, and on the x-axis transfer criteria from 0 to 6, the number in each circle represents a number of programs that ranked themselves like that. So let me draw your attention to the programs that are doing relatively well. So about 38% of the programs had 4 or more transition criteria and 4 or more transfer criteria in practice. Whereas on the bottom part of the row, we have almost 60% of the programs which had no transition criteria in practice. And this is just published 3 years ago. So collectively, we can do better than this, and we need to do better than this. So what does the evidence show? Unfortunately, most teens and young adults with congenital heart disease have limited knowledge of their heart, and there are a number of publications, I've not listed them all here, that demonstrate this. But a very interesting study done at Sick Kids, published in 2009, pointed out that teens who are knowledgeable about their congenital heart disease are more likely to be confident communicating directly with their doctor or nurse, rather than have their parents do so. And so this got me thinking that knowledge is confidence. We often think as knowledge being power, but knowledge is confidence, in my opinion, for young adults and adolescents with congenital heart disease. So I and colleagues in Edmonton, we set out to evaluate the impact of an educational intervention for adolescents with congenital heart disease. And our aims were twofold. First, to develop and evaluate a clinic-based transition intervention. And second, to measure CHD knowledge and self-management pre and post-intervention. And we called this a chapter study. It was a randomized clinical trial of 15 to 17-year-olds with moderate or complex congenital heart disease. And there were 2 groups. Those in the intervention group received a nurse-led one-on-one teaching session that lasted about an hour, and the control group had no intervention, although their cardiologist may have explained aspects of transition to them, but that was certainly not protocolized. Here's one of our clinic nurses, Michelle, and a patient who agreed to have her photo taken. And the intervention protocol is listed here. So a brief discussion of transition and what that meant. Then the nurse and the participant created a health passport together, which reviewed the names of their cardiac conditions, their previous caths and surgical interventions, the name, dose, and rationale for their medications. They reviewed a diagram of the participant's anatomy and discussed potential late cardiac complications, and tied in the need for lifelong follow-up. The participant then was given contact names and location of the adult clinic. They discussed some risk-taking behaviors using third-person scenarios. They were given some youth-friendly take-home written materials about sex, drugs, and rock and roll, and they were introduced to some patient-oriented congenital heart disease websites. And then the nurse followed up with a participant by text or email within 7 days. And that was it. A low-cost intervention. It certainly takes some nursing time and some space in the clinic, but nothing particularly fancy. And we looked at knowledge using the MyHeart score at 3 time points: enrollment, 1 month, and 6 months. And the intervention group in green had higher knowledge of their congenital heart disease, as you might expect at the 1 month point. And I was worried that that was going to completely drop off by 6 months, but their knowledge was maintained at 6 months, and that's probably because they had a health passport, which was provided to them, and many of them had it on their phone. And so they weren't expected to memorize things, but they knew where to look up the data. We also looked at self-management skills on the y-axis at these 3 same time points, and we were a bit surprised, but pleasantly surprised to see that the intervention group in green had higher self-management scores by 6 months after enrollment compared to those in usual care, even though the nurse had done nothing to counsel them or teach them about self-management skills per se. So what do I mean by self-management? Well, it's generally viewed as a set of methods, skills and strategies by which individuals with a chronic health condition can effectively take care of themselves, in partnership, of course, with their healthcare team. And self-management requires some knowledge of the health condition, some problem-solving skills, access to and confidence and support, so knowing where to turn to when things go awry, and of course having some emotional well-being. So you can usually imagine that mental health challenges, anxiety and depression, for example, if significant, can certainly get in the way of self-management skills. So in the Chapter 2 study, we wanted to ask a few different questions. First, what is the role of a nurse-led one-on-one coaching session that's focused on self-management? Second, do transition interventions impact adult clinic attendance? And third, what is the long-term retention of CHD knowledge past the 6-month time point? So the Chapter 2 study was also a clinical trial. It was of 16 and 17-year-olds. And it was similar to Chapter 1, except that there were 2 intervention sessions with the nurse, not one. And there were 2 sites, Stollery and Sick Kids, and it was a larger study, 120 subjects. And the aim of the nurse in session 1 was to inform youth about their heart condition. And it was very similar to what I described with the Chapter 1 study, but it also included some goal setting, which they were to do before they met with the nurse a second time. And it involved visiting the adult clinic, which I can tell you the participants really appreciated. It certainly reduced some anxiety knowing exactly where they were going to go for their first adult appointment. And then the second session, which was held about 2 months later, the aim was really to motivate the youth regarding the development of self-management skills. And the role of the nurse was more of a coach or facilitator rather than a teacher. Again, the duration was about 60 minutes, and the content included some goal setting again, learning how to make an appointment, how to get ready for an appointment, how to prepare yourself with the information you want to convey to your doctor and nurse, and also filled how to complete a prescription, and there were some role-playing scenarios as well. And what we found in terms of our primary outcome was that the probability of attending the first adult appointment was more timely in the intervention group in blue compared to the usual care group in orange. And what we have on the x-axis here is excess time, that variable that I was telling you about earlier. The greater your excess time, the more delayed your first ACHD appointment was. With respect to knowledge, the intervention group in blue had significantly higher knowledge of their congenital heart disease, which was quite well maintained out to 18 months. And with respect to self-management, using the Transition Readiness Assessment Questionnaire, we found that the intervention group again had higher self-management scores relative to those in the usual care group. But of note, we did find that those in the usual care group had increasing self-management scores over time as well. And I think this really highlights the importance of having a control group when you're measuring self-management in young adults. Because if you don't have a control group, you don't really know for sure whether your interventions helped. We did a qualitative data analysis as well, finding out from participants what aspect of these 2 teaching sessions they valued the most. And this is what they told us: creating the health passport, the goal setting exercises with the nurse, and the role playing with the nurse in the second session were the aspects that the nurses, that the participants found most meaningful and relevant to them. And I can tell you that as the as part of the study team, what I felt that we really learned was that you really need dedicated nursing time to make this happen. You need some dedicated teaching space within the clinic area. Interventions need to be on the same day as a clinic visit. It's because that's when they're a captive audience, when they're in your waiting room. We also learned that parents really struggled with being left out of these sessions. In fact, we had a couple of parents who insisted on being part of it, but most did not. And finally, we learned that health passports need to be smartphone friendly. And so some of the standard aspects of a phone, like the calendar function, the contacts function, the notes function, and the camera, these are what we use to help participants develop a health passport on their phone. Of course, there have been a number of other important and terrific publications on the effectiveness of structured formal transition preparation. So Eva Goossens, for example, and Philip Moons, Karen Uzark, Magali Ladouceur, Stephanie Guidos have all published outcomes of transition intervention programs. This is a paper here from McMaster where they've done a fantastic job. Nora Yap from the UK, Ewelina Bratt and Philip Moons published a fascinating study involving 7 programs in Sweden, the Stepstones Transition Program, where they had a very comprehensive intervention that involved not only a transition coordinator and structured teaching, but the Stepstones program also involves a parent intervention and a group session for adolescents. And they demonstrated an improvement in patient empowerment in the intervention group. Of course, there's publications on virtual reality and 3D models and how they can be used for educating adolescents about their congenital heart disease. So there are plenty of other important publications out there. And this is a slide that Kayla Lopez from Texas shared with me, and she and her team developed something that they call the Congenital Heart Health Activation Transition Tool. And this is something that forms the basis of an education program that is conducted over time, usually at least 3 different visits. Step 1 for the first visit, step 2 and step 3 for the second and third visits. And basically at the onset, they show the adolescent or young adult what they need to know and where they're going to get to. And so it sort of primes them for, here's what you don't know, here's where you need to get to. And I think a similar tool could easily be applied in many different clinics, including in adult clinics. So there's some evidence. What about where is the evidence currently lacking? Well, when you think about potential transition interventions, and this is not an exhaustive list, but here's a list of some of the interventions that could be done. We've talked about teaching teens about their congenital heart disease and developing self-management skills, and I would argue that we definitely have some data in these departments now, but there's not much really known about patient navigation, peer mentoring, parent support, the potential value of young adult clinics where there are waiting rooms just filled with 18 to 25-year-olds rather than 18 to 80-year-olds. And young adult clinics could also have fewer patients and spend a bit more time per patient. The role of technology and group-based transition preparation is also really lacking evidence at the present time. But here's a really interesting study in type 1 diabetes that I want to highlight. It's a Canadian study. They looked at 17 to 20-year-olds, and half of them were randomized to work with a transition coordinator, and the other half were not. And this transition coordinator worked with them during the last 6 months of their pediatric care and the first 12 months in adult care. And what the investigators found was that the transition coordinator group had increased clinic attendance, greater satisfaction with care, less diabetes-related distress, and a trend towards a lower hemoglobin A1C, although no change in rate of DKA or hypoglycemia. And as a cardiologist, I'm often looking at other chronic disease populations to figure out, well, what can we learn from our colleagues in endocrinology or rheumatology? And I think that this is an important study because we in congenital heart disease need to think a bit more about patient navigation and how that could help. I think a navigator could help in terms of a variety of different domains. They can help adolescents and young adults develop self-management skills. They can help them navigate the complexities of the medical system. And navigators who are social workers by training are terrific at addressing some of the socioeconomic barriers to getting care, such as being able to get to the appointment in the first place, for example, bus tickets. Navigators can provide an in-depth initial assessment, identifying the participants' needs, creating some goals together. And for those who have challenging social determinants of health, who come from lower socioeconomic backgrounds, for example, having a navigator is really an opportunity to increase healthcare equity and accessibility. So colleagues and I in Alberta right now are leading the Transition Navigator trial. This is a pragmatic RCT. We're enrolling 16 to 21-year-olds with a chronic health condition. The goal of this study is to evaluate the effectiveness of a patient navigator. It's not limited to congenital heart disease, so we are including patients with other pediatric onset chronic health conditions, and we're collecting quantitative and qualitative data. And the primary outcome is the rate of emergency room visits. Half of the participants are working with a navigator who's a social worker by training for 24 months, and the other half are not. And the navigator is able to take on a whole person approach, so they don't just look at their heart, for example, or look at their kidneys. And our navigators are trained to provide liaison with schools, universities, employment offices. They can help with housing where needed. They can help with educational opportunities, provide referrals to mental health and addiction, and provide financial assistance. So they really do provide a very holistic whole person approach. We've enrolled 335 patients. The quantitative analysis is ongoing, but we have done qualitative data analysis, and the major themes that come out are emotional support provided by the navigator, and here's some quotes from participants, task focus support, and guidance to become more independent. In other words, the role of developing self-management skills that the navigators have really taken on. So more on the Transition Navigator trial to come. I also want to say a word or two about peer mentoring. So there's a terrific program developed at Sick Kids called iPeer2Peer, which has been evaluated in a number of other chronic health conditions listed here. And it involves some one-on-one virtual peer mentoring sessions with peers that are typically 3 to 4 years older. That is, the mentors are 3 to 4 years older than the mentees. And they meet about once a week virtually over a 3-month period. And currently, I and my colleagues at Sick Kids are planning a multi-center collaboration in congenital heart disease, which will exist in parallel with an iParent-to-Parent co-intervention program. So very excited about this work and grateful to my colleagues in Toronto for this opportunity. And I also want to make a comment about technology. So here's an interesting study published about a decade ago now. They interviewed adolescents and young adults. They did some focus groups as well. And the question they asked them is, what tools would aid in the transition process, with an emphasis on technology and social media? And here are the 3 themes that came out. Having support groups with other teens. Well, that was really interesting to me because that has nothing to do with technology at all, but this is what they said. A preference for text messaging, meaning being able to do that with healthcare providers. And finally, the desire for access to an online health management program. With respect to this third one here, I developed with colleagues at McGill University and McMaster University, we developed something that we call the MyReady Transition app. And this is an app that we're currently evaluating. It's got 20 modules in it. Includes something that we call a Smart Heart Pass, where they can develop a health passport within the app. There are some testimonials, brief videos, usually about 30 to 40 seconds in duration. Testimonials given by young adults. There's some questionnaires that they complete. The transition Q is a measure of transition readiness, for example. And these are just some of the screenshots from this app. And we're currently evaluating this in the Ready or Not study, which is a randomized controlled trial comparing the app versus nurse-based teaching. Like I said, there are 20 modules. Each one takes 10 to 15 minutes. So it is a fairly time-consuming app for participants to go through. There are 4 sites that are enrolling patients, Stollery, Sick Kids, BC Children's in Vancouver, and St. Justine in Montreal. And we've enrolled 207 patients, and we're finished recruiting now, but we'll be following participants through to September 2025. I also briefly want to mention health literacy. So health literacy is the degree to which an individual can access, process, and comprehend basic health information in order to participate in health decisions. And we know that from the general adult cardiology literature, that low health literacy is associated with higher cardiovascular morbidity, mortality, and healthcare costs. And you can imagine that our young adults with CHD who have challenges with executive function and some cognitive impairment or adverse social determinants of health can really struggle with health literacy. And we know that the health literacy in our patients is associated with the social determinants of health, such as education, race or ethnicity, wealth, the community that they live in, their proficiency in English, at least in the United States. Obviously, that language would be different in different countries. So there's a tight link, in other words, between the social determinants of health and health literacy. And this is important to my colleagues in adult congenital heart disease because patients who have limited health literacy become increasingly disadvantaged in adulthood relative to childhood. In other words, the impact of health literacy increases later in life, something that you really need to keep an eye on and pay attention to in the adult clinic. So I'm going to leave you, I hope, with some practical tips. In terms of working with young adults, try to meet one-on-one for at least part of the visit, even if parents or partners show up. Meeting one-on-one really gives them the opportunity to share some concerns that they may not otherwise share with a patient, with a partner or a parent in the room. Coordinate your CHD education with routine clinic appointments, because that's when they're available to do so, and they're not going to no-show if they're already there in the waiting room. And that can apply to in-person appointments or virtual appointments. Remember to progress at their own pace, which will be highly variable from one young adult to the next. Continue CHD education upon arrival in the ACHD clinic, rather than assuming that they are understanding of their congenital heart disease when they arrive for the first time. Emphasize the need for lifelong care, and of course, please accommodate for low health literacy and or deficits in executive functioning. Be non-judgmental. 18-year-olds are not 40-year-olds, and they're not going to be able to function at that level. And they can tell when you're not being genuine. Give them control over the topics that are discussed as it relates to transition. Ask them about their interests and goals, and seek feedback. Is the transition preparation that you're getting here in the adult clinic, is this really meeting your needs? Try to remember how you felt at that age. It was a long time ago since I was 21, but I do try and remember what it's like being a young adult. Acknowledge that transition can be an overwhelming task for them. Encourage and congratulate them as they make steps in the right direction. And if you have a social worker to help you, provide them with tangible goods like meal vouchers or taxi vouchers or bus tickets if they need them to get to appointments. And as a cardiologist, of course, we can't do this on our own. There's no way that we have the time or skills, to be honest with you. So we need nurses and social workers and psychologists to help us and our patients in this process. And keep in mind that the hardest to engage are patients with comorbid mental health conditions, low SES, food insecurity, and addictions. Basically, if their physiological needs and safety and security are not in place, then actually managing their congenital heart disease, which is at the tip of the pyramid, is not going to happen. And finally, a comment on working with parents. If you do have helicopter parents, which I'm sure you do occasionally, because I certainly do in my clinic, explain the rationale of fostering their young adult child's independence, inquire about their concerns, don't completely exclude them from the conversation. They do have some insights that will be worth hearing about, and reassure them that, at least from the perspective of their young adult child, they're still part of the overall team. Many 18 or 19-year-olds still do actually turn to their parents for help and guidance. Just to put all of this together, here's a figure put together by Philip Moons and others. Here are some of the steps that need to happen, not only in the pediatric age range, but also in the adult range, adult clinic. This includes monitoring continuity of care, not only in the adult setting, but of course we need to do that in the pediatric setting as well. In late adolescence, we need to introduce the ACHD team to our pediatric patients, and we can do that in a variety of ways. We can take them to the adult clinic if it's close by, or if that's not feasible, we can provide a brief video about the adult clinic or brochures or flyers. It doesn't need to be complicated. Facilitating peer contact, this can be done in a variety of different ways. I mentioned peer-to-peer support, which is certainly a more complex program and needs further evaluation, but you can have an annual adolescent day or an annual young adult day, because they really do appreciate having the opportunity to meet other young people who have the similar condition to them. Of course, on a one-to-one level, developing and working with them and developing a transition plan, counseling and education, and going through a risk assessment in terms of a head screen. And of course, guidance of parents through all of this. Really interesting study from my colleague Michelle Keir and colleagues in Calgary, where they did a research priority setting exercise among adolescents and young adults through focus groups. And two of the research priorities from the perspective of patients related to transition. The first was creation and trial of an electronic support program to ask questions of the adult clinic during transition and beyond. I thought that was really interesting. And second, a formal assessment for anxiety, depression before transition and providing mental health supports as needed. What about transfer? Well, we got to get this right. And there are responsibilities of both the pediatric program and the adult program. The pediatric program needs to inform patients well in advance of what's going to happen and how it's going to happen. The pediatric program needs to consider the developmental age of patients in terms of the timing of transfer, and they need to provide a comprehensive transfer letter to the adult program, as well as a health passport to the participants or patients. The adult programs need to have a strategy for tracking referred patients. They ideally will track time intervals between pediatric and adult appointments, and track how well they're doing in terms of excess time. And of course, informing pediatric colleagues of the transfer outcome. As a pediatric cardiologist, I really appreciate getting letters from my ACHD colleagues hearing how my patients are doing. So if we go back to our case here, I think that if he had, at least I like to think if he'd had a transition program and he knew the name of his congenital heart disease, or at least he had it on his phone, and if he knew that he wasn't cured and needed lifelong care, and if he was aware of some of the potential complications later on in life, that he may have not ended up in this walk-in clinic. So we need to aim high as a congenital heart disease community. This might sound naive, but this is ultimately what we need to strive for. All patients arriving in the ACHD clinic in a timely manner with basic knowledge of their CHD, a health passport on their phone, and some basic self-management and self-advocacy skills. Patients need to feel engaged with their ACHD providers and want to return to the ACHD clinic. There needs to be equitable access to care, by which I mean that adverse social determinants of health are addressed to mitigate barriers to accessing care, and that we collectively have the time, space, and human resources to do all of the above. So I leave you with a call to action. All young adults with CHD should receive one-on-one teaching about their CHD and self-management skills. Young adults with adverse social determinants of health or mental health challenges need extra time and resources from their clinical team. And finally, let's engage more young adults with lived experience as partners in the research process and collaborators rather than just research participants, because we can learn a lot from them. Transition to the ACHD clinic, mission complete or failure to launch? Well, I would say that we're not in outer space yet, but we're off the launching pad, maybe a couple hundred meters off of the launching pad. This movie came out, about 15 years ago now. Sarah Jessica Parker and Matt McConaughey. He's a 30-something-year-old still living in his parents' house with no job and no interest in getting a job. And he's, even though he's 30, he's behaving like he's about 17. And it's an entertaining movie, but this is not what we want for our young adult patients with CHD. So please consider this. What a missed opportunity it would be, having invested so much in these young adult people throughout childhood, to not set them up for success in the adult system. We have the collective responsibility to instill relevant knowledge and skills in young adults that will set them up for success in managing their healthcare over the long term. And I'd like to acknowledge my many collaborators in the chapter studies, the Transition Navigator trial, and the Ready or Not study, including my ACHD colleagues here in Edmonton, led by Isabel Vandermeulen, who've been very supportive of my research. Erwin Uxlin was part of our chapter studies as well. And I'll just leave you with some practical guidelines, Canadian, American, and European, and my email address is here if you have any questions. Thanks very much for your attention.
So thank you, Andrew, for an excellent talk and an excellent review of the topic. So if anyone has any questions, please just either write it in the chat or feel free to unmute your microphone and ask the questions. While you are thinking about your questions, so I probably will start. So Andrew, I think that so one of I think is my personal perception. I would like to get your thoughts about this. One of the main gaps in transition is the lack of involvement of the adults teams. So we have this idea that transition is a pediatric problem. From transfer, the patient is you see the patient in your clinic. As a pediatrician, you do all these interventions in the transition clinic. You transfer the patient, it's like nothing happens, and there is. I like this idea of the navigator, but what about having a transition program in the adult side that actually take care of that patient when the patient moves across? Either way that you have. I work in two centers, one with vertical model, another one with horizontal model, and the problems were the same. The vertical model was easier because the patient was in the same building, but we had the same problem that the patient was transferred to the adult clinic, and suddenly nothing happened on the adult side with that patient. Don't you think that we are not really getting the message to the adult units that this is not just a pediatric problem, but actually probably more an adult problem that could resolve many of these loss to follow-up that we have after transfer?
Yeah, thank you for your comment, Rafa. I completely agree. I do think that there's increasing recognition in the adult community that transition is part of their responsibility. I think that the pendulum is slowly swinging, but we do have more work to be done, absolutely. Like I tried to point out, that the transition process is not done by the 18th birthday in the vast majority of our patients. And there is certainly a dual responsibility of both pediatric and adult programs. I think that a good starting point, just in terms of thinking of low-hanging fruit, a good starting point is to identify a transition champion within each ACHD clinic who's going to take responsibility, not necessarily for all of the patient level teaching and education, but is going to take responsibility for making sure that transition as a topic is not ignored within the adult clinic. And the transition champion doesn't need to be a cardiologist. In fact, it may be more effectively done if it's a nurse or a social worker, someone who may have a little bit more time to make sure it happens. I'm really curious about the notion of young adult clinics. And I would love to see some more literature on that. And I think that a young adult clinic that, again, has fewer patients scheduled and allows, therefore, a bit more time on a per patient basis and incorporates not only a visit with a cardiologist, but also a visit with a nurse and or a social worker or psychologist would really be helpful to some young adults as they enter the clinic for the first and second and third visits. But absolutely, this is a problem that our adult clinics need to consider to be, a responsibility of theirs as well.
Mhm. So there is one question in the chat, but before the question, I want just to acknowledge the comment from Erwin and Adrian that is online, that's saying that you have excellent talk, and Erwin said that thank you for moving this topic forward and having an impact on healthcare in every patient. So thank you, Adrian and Erwin. And there's a question here that say, if you have come in the process of doing transition, have you come across with any platform that can share medical reports or interventions or patients information that can be managed by the patients themselves, not just your app? So if there is any platform that you are aware of where people could use, and I mean, I love the idea of the app, so I really, really think it's a great idea, but might not be accessible to everyone at this stage. Do you know if there's any platform where people could use already to share this information?
So there are some electronic medical records in many jurisdictions now that give patients some access to their healthcare information through a patient portal. And and I know, for example, that there's one at Sick Kids. And that can be used potentially to create a health passport, a concise summary of the important pieces of information that a young adult might need about their congenital heart disease, like the name and of the congenital heart disease and the name of their interventions. And so I think that there's lots of potential for electronic medical records to function as a source of information for patients by providing a health passport.
So one of the things, just to comment on that, we have Epic here, and so the patient has an app, can access to the app, and they can just with a click get at least the last clinic letter. So and then if in your clinic letter you have for the diagnosis stated there, then the patient can share it. I always recommend them. I actually download the app in clinic with them and force them to have the app in their phone, just in case they get anywhere, and at least they can download my letter and see that and show it to any physician wherever they go. So I think that Andrea could ask you a million questions. I have one more question just to finish, because I think you touch upon that, and I wonder what is your opinion about using telehealth to educate the patients and to use it as a part of the transition programs.
I think that one of the silver linings of the COVID pandemic is that we're all much more adept at virtual healthcare delivery, and I think it's terrific. And in fact, we're using Zoom here in Alberta to do transition preparation and transition teaching between nurses and patients. And of course, in Canada, we have a vast geography, and many of our patients live many hours drive away from tertiary care centers, and I think that virtual health absolutely plays a very valuable role. And our experience has been that young adults are very receptive to getting transition teaching over virtual health, and it's pretty easy to do. So yeah, it works well.
So I have a last question from Jane Heggie. Jane Heggie is one of our anesthetists here who is working a lot in transition with our databases. They said in Ontario we have 2 million plus individuals without a family doctor. So, and she wants to know, do you have the same problem in Alberta, and do you allow patients to self-refer to the programs, and even if our patients are out of province?
I didn't quite catch the second half
So the
of the
thing,
question.
the idea is do you have, so if you don't have a family doctor, you cannot have a referral. So do you allow the patient to call in and say, well, look, I have congenital heart disease, can I come to your clinic? Without having a doctor's referral. I guess that is a more an
Yeah,
adult problem than a pediatric problem.
yeah. Well, we definitely have the same problem of lack of family doctors in Alberta. That is for sure. In the pediatric clinic, we take referrals from nurse practitioners as well as family doctors and pediatricians. I can't comment on my colleagues in the adult clinic. I think that an excellent point has been raised, though. You know, if ACHD programs recognize that many patients don't have family doctors, then maybe that would be a good reason to accept referrals directly from patients. I see no reason why not to. But in the pediatric world, that's I would say a bit less of an issue. We do encourage our patients to come back earlier than need be, earlier than initially planned if they have any new concerns. But I think that ACHD programs accepting referrals directly from patients, I think that's a great idea.
So just to comment to you to this, Jane. So we don't really have many patients self-refer, but at least probably I would say this always around 10 patients a year that they email us and say, look, I was a patient in sick kids, haven't been seen for 3, 4, 5 years, and I don't have an appointment. So the answer is yes. I say yes to all of them, and there's no referral, but we get them and see the patient was in a ACSD in a congenital heart disease program before the patient definitely comes. So I could be asking you many questions, Andrew, about the topic. I think it's a fantastic and fascinating topic, but we are already 10 minutes over the hour. So thank you very much for the excellent talk and the excellent review, and to all of you, thank you for joining us, and good morning, good afternoon, or good evening, wherever you are in the world. And thank you, Andrew, again for an excellent talk.
Thank you,
Bye-bye.
Rafa, for having me.
Bye.
Have a good day. Bye.